Hello everyone, Dr. Bice here. Going to talk to you now a little bit about pediatric gastrointestinal disorders. So pediatric GI disorders are actually very common in pediatrics. In fact, when we think about the most common pediatric disorders, really in that list is going to be ENT issues, GI disorders, and allergy and immunology issues. So it's really important that you have a great grasp on pediatric GI disorders because you're probably going to be seeing those a lot in your clinical preceptorships and also in practice if you are doing family care or pediatrics. So first, let's get a little look. We're going to bring this picture up first. Get a little look about what the basic GI system includes. So, and I know you guys already have a good idea of what the GI system really means, but it's important for you to just get a good look again at what all body parts, organs and body systems are included in the GI system for children. So really the gastrointestinal system begins in the mouth, okay? And digestion actually begins with salivary enzymes that begin also in the mouth, okay? So in fact, the most common gastrointestinal disorder in children is dental caries. And we will talk about dental caries in you'll learn more about dental caries in the oral disorders for children. But again, just know that the gastrointestinal system begins in the mouth, goes on through the esophagus, and includes all of the gastrointestinal organs. And that is the liver, your gallbladder, which the liver and gallbladder are connected, your stomach, which is over here on the left side of the body, pancreas, your small intestine, which then leads into your large intestine and your rectum. Any one of these areas of the body can be included in a gastrointestinal disorder or functional problem. So it's important to have a good idea of really where these things are, because a lot of times pain or other symptoms are associated with the area that the actual organ or part of the body in the GI system is located. All right. So the other thing that I wanted to talk to you about getting started is some common diagnostic studies, okay? Now, I'm not going to really go over any pictures for this right now. This will just be some listening, but some of the most common diagnostic studies you're going to see for kids who have abdominal pain, gastrointestinal disorders, or GI chief complaints are going to be a UA. Okay, so anytime you have a child who complains of abdominal pain and possibly, some urinary pain, and a UA is something you want to keep on your list of actual diagnostic studies on whether or not that's needed, especially little girls. So take a look at the little girl on this screen here. She's grabbing her belly, but her abdomen is really close to her bladder. Okay, so a urinary system and a gastrointestinal system is really quite close in a child. So a UA is something you may need to consider ordering depending on all of the characteristics of the symptom that you collect and what's going on with the child. Another diagnostic study you may be ordering or considering with GI complaints is a CBC. So a complete blood count can kind of tell you a lot about what's going on with the cascade of your fighting infection cells. So how high is the white blood cell? What are the platelet counts? All of those things in a CBC can relate and help you make your diagnosis in a GI system disorder. Other things would be serum chemistry screening. Okay, so like maybe a CMP or a BMP. You may not need a complete metabolic panel. You may just need to see a basic metabolic function. ESR, okay, erythrosedimentation rate is something that measures inflammation along with the C-reactive protein. A CRP or C-reactive protein tends to be just a little bit more sensitive with regarding inflammation in bacterial infections, but an ESR or erythrocyte sedimentation rate can also give you an idea of total body inflammation and can help. Some of the things you might be considering if you're ordering an ESR or a CRP are things like inflammatory bowel disease, things like an infection in a neonate. Okay, CRPs are frequently ordered for suspected infection in a neonate because they're so young, and a CRP is very sensitive to bacterial infection responses in young babies. Also, stool examinations. Okay, so do you need a culture of stool? Do you need a stool for O&P? Kids who have diarrhea or common abdominal pain complaints with loose stool may need to have a stool culture or stool O&P for parasites and ova, and that ova stands for eggs, looked at. You may need to order a blood culture. Okay, it's not as common to order a blood culture in primary care, I will tell you that. If any of your infants need a blood culture, then they probably should be seen in the emergency room. Okay, but it's possible that you may be considering that. If you work in a more acute care area or an urgent care area that sees pediatrics, you may be ordering blood cultures more often than someone who works in the primary care setting. pH and reducing substances. I love a pH and reducing substances. That is a test that I order actually quite frequently in kids who have abdominal pain and diarrhea complaints. In my opinion, it's a widely underused study, and it's really great to order when you are considering or thinking about malabsorption of carbohydrates. Okay, so one disorder that comes to mind immediately is a lactose intolerance. If you have a kid that's coming in vomiting, having some diarrhea, bloating, achy, irritable, and mom is just like, I cannot figure out what's going on with the stools and why he is just so achy, you may consider ordering a pH and reducing substances to look for the presence of elevated reducing substances, because that would tell you that there may be a carbohydrate malabsorption issue. And in addition, the pH may be low because when you have a problem with breaking down those carbohydrates, the pH of the stool is going to be more acidic. Other things you may consider are fecal fat. Okay, urine pregnancy test is one if you're, got GYN complaints in a female, or possibly GYN and or GI kind of mixed. All right, urine test for gonorrhea or chlamydia. Pap smears you're probably not going to be doing in primary care unless you're in a family clinic or a women's health clinic. Sometimes we do them in peds, but it's very rare. And the main reason is because new recommendations actually state that we should not be messing with a young girl's cervix until she's 21, despite how many partners she has had. Okay. Radiography. Okay, some of the things that you may be considering ordering as far as radiology tests with your GI complaints are going to be ultrasounds, obviously abdominal ultrasound, okay, an abdominal x-ray, upper and lower GI series, okay. Air contrast enema is usually used for diagnosis or treatment of intussusception, so that's done more in the emergency room, but it is something that you should know about. Also, chest radiographs, if you're kind of thinking that maybe the pain that the child is having in the abdomen could actually be a referred chest issue, you may consider getting a KUB in a little infant or a chest x-ray. But CT, your more expensive examinations like computed tomography is reserved for when you really, really think there's something emergent going on with the child. You should not be ordering a CT of a child's abdomen unless you're really considering a major illness, such as, appendicitis. And a lot of times, appendicitis now can actually be diagnosed with an ultrasound in the emergency room. Okay. Other less common things that you would consider ordering in primary care are going to be MRIs of the abdomen, nuclear medicine tests. Okay. Nuke med scans, kind of like a gastric emptying scan. Sometimes we have kiddos who are really got severe issues with vomiting and abdominal pain, and we'll want to see if they're having a delayed gastric emptying. A lot of these more expensive tests, guys, are reserved for a specialist. My head usually goes to, if I'm having to order a really seriously expensive examination or diagnostic or ancillary study, I'd really rather have the opinion of an expert first. And most doctors or practitioners or physician's assistants who work in specialist care for GI would rather you send the kid to them more abruptly or immediately than order a bunch of expensive tests that they don't feel are necessary. Okay, and that's simply because they have the expertise to say, I think it's probably not that, maybe more this and this, and it can narrow down the cost for the patient, narrow down the cost for the medical system, and then also decrease the ordering and also resources that were not needed. All right, so let's move on to discussing some common upper GI and lower GI issues. All right, the first thing I want to talk to you about is vomiting and dehydration. Okay, vomiting and dehydration is something you're probably going to see in kids quite often. Okay, now vomiting in children really requires an excellent history because there are so many things that can cause vomiting in kids, and you want to make sure that you are using your pertinent positives and pertinent negatives to your advantage when you're talking about the history and getting a good physical exam, because that will help you pinpoint your diagnosis most of the time. So the most common conditions that you're going to see in children with vomiting are going to be gastroenteritis. Okay, usually viral gastroenteritis. In fact, the overwhelming percentage of gastroenteritis in children is viral in nature, not bacterial. So if you have a child who has vomiting and diarrhea and you suspect gastroenteritis, it's more than likely that you're going to be diagnosing a viral or acute gastroenteritis that is viral in nature, not bacterial. Next, gastroesophageal reflux disease. Please remember this is not the same thing as gastroesophageal reflux. There's a difference between GER and GERD. An infant or child who actually has the disease is going to have more pathological manifestations with GERD than with GER. Overfeeding. Okay, so overfeeding is an issue that can actually cause gastritis in both children and adolescents, and we do see this a lot in infants. Sometimes, it's really common for parents, and I remember even doing this with my own child, not sharing if the baby is hungry because they're crying and they're screaming, so you feed them more. Sometimes babies will be eating 4 to 6 ounces at 3 weeks old in a feeding, and you're like, whoa, that's probably a little bit too much for that little baby belly. One of the things I love to tell parents, and I actually have a little glittery, kind of like a sequency tiny ball around the shape of a quarter. It's sphere, but it's around the shape of a quarter. I keep that on my badge when I go to work, and I will tell parents, this is the size of your neonate's stomach. And imagine putting this 4 to 6 ounces in their belly. It is made up, I don't tell parents this, but I'm telling you, the stomach is made up of transitional epithelium, meaning that it is really nicely elastic, so it will expand and contract back to normal size well. However, even if you overfill a balloon, it'll pop, right? So we want to think about the same thing with children and infants' bellies, that if they are overfed, the first place it's going to go is boop, right out in a vomiting episode. Okay, so next, we're going to be thinking about obstructions, okay? Pyloric stenosis is one. Malrotation with intermittent volvulus. Intestinal duplication is one of the least common ones that I would see in this list. Hirschsprung's disease. Foreign bodies or incarcerated hernias. These are all things that should be on your differential diagnosis list when you have a child who has abdominal pain, depending on the pertinent positive and pertinent negative. Okay, so Hirschsprung's disease. That is a disease of the GI ganglia, okay, the neuroganglia in the GI tract, where it essentially just does not work very well at the end of the tract. So children are born with this, okay, it is congenital, and they end up having some real difficulty evacuating stool because that stool sits kind of at the end of the GI tract and they can't get it out. And then they end up just backing up more stool and more stool and more stool, and they can actually end up with what's called megacolon, which is a very dangerous medical emergency in children. Okay, and typically Hirschsprung's disease is found very early on in infancy, a lot of time in birth, okay, because of a problem with ileus or because of problems we're seeing with stool evacuation as young as neonate, 24 to 48 hours old. And in those cases, they do have surgical correction with an anorectal pull through, and they usually end up with a great prognosis. Pyloric stenosis. So this is a disease that you see in babies, okay, and typically the onset is around 4 to 6 weeks old. It is more common, far more common in boys than it is in girls, and it is also more common in firstborn males than it is in beyond the first child. Don't ask me why. We don't have a real good, strong understanding of why firstborn males is who it affects more. But if you have, it also additionally affects Caucasian babies more than it affects any other race. So if you have a 4-week-old infant who proceeds or presents to see you with projectile vomiting, because that is commonly what is seen in pyloric stenosis. We'll talk a little bit more about this in the perinatal disorder section, but if you have a 4 to 6 week old baby who is Caucasian and male and presents with pyloric stenosis, you are going to be considering pyloric stenosis in your differential diagnosis, okay? All right, so let's move on just a little bit. Some systemic infections you may be considering with vomiting would be UTI, pneumonia, or hepatitis. Hepatitis is going to be the least common in this list right here. UTI and pneumonia far more common in children. It is really, really common for kids who have a urinary tract infection with a fever for them to vomit. So if you have a kiddo who comes in, especially in infancy where they can't talk and tell you that they're hurting, fever, vomiting, lethargy, just overall not feeling well in infancy, especially young females, you would want to consider UTI and looking at that child's urine as part of your differential in your plan, because many children who come in with fever, no other symptoms. Okay, so I'm talking about a kid that doesn't have runny nose and congestion and cough. I'm talking about just fever, vomiting, and lethargy, and just in general unwellness, not feeling good. Even febrile seizures in accompany with that, you would want to assess for a UTI. Children who have pneumonia also do have episodes of vomiting, and sometimes this is what we call tussive emesis. So they're coughing so much that they vomit. Okay, or they're just feeling generally unwell from their dehydration, so they will vomit because of that as well. All right, so two of the less common differential diagnoses for vomiting in children are pertussis syndrome and otitis. In pertussis, children have a very strong paroxysmal and whooping type of cough that can lead again to that tussive emesis. It's very painful, and infants especially will vomit. And then otitis media, when you think about your ears being affected, you think about swollen eardrums. You know, what's behind your eardrums? Your inner ear, which really affects equilibrium. And kids who have otitis media can also get headaches. So sometimes we will see vomiting in children who have ear infections as well. All right, let's move on a little bit. We'll talk about types of dehydration. Okay, where's that at? So, hang on, I've got both. There we go. So first I want to talk about the stages of dehydration, okay? This is essential because when you see children who have dehydration, you're going to need to know, does this child need to stay in primary care for follow-up? Does this child need any follow-up at all? Or is this child at a point where I cannot handle what they've got going on in primary care and they need to be seen by somebody else in a tertiary care center? Okay, minimal to none dehydration is something you can manage in primary care, no problem. In fact, a lot of these kids won't even need any kind of follow-up, okay? They're going to be totally alert. They're drinking normally. Okay, the heart rate all the way down through their pulses, breathing, eyes, and tears are nice and normal. Tears are present for you. Okay, they're crying, but you can see the tears falling from their eyes. Their mouth and tongue are going to be nice and moist. Okay, skin recoils really good, so you're not seeing any turgor issues. Capillary refill is normal. So for a child or an infant, we like to see less than 3 seconds or right at 2 seconds for cap refill. Their extremities should be nice and warm because that means they're well perfused, right? And then their urine output would be normal to maybe a little bit decreased. Okay, that's none or minimal dehydration and less than 3% loss of body weight. And that would be something that could be easily managed in primary care if that was the only issue going on. Probably no follow-up necessary. Mild to moderate dehydration is going to be anywhere from 3 to 9% loss of body weight. Okay, these kiddos you might need to monitor. Maybe call, follow up with at home the next day, or see back the next day if you're thinking it's more on the moderate side. Okay, these kiddos may be a little bit fatigued, all right, or restless, irritable, of course, because they're just not feeling super hot. They are thirsty and they are eager to drink, okay? normal to increased heart rate. Now remember, with heart rate, tachycardia is an early sign with dehydration. If you're seeing a child who is dehydrated and they're bradycardic, that is a late sign. That is something that needs extreme or emergency services right away. Okay, again, heart rate that is elevated or tachy is an early sign. Bradycardia is a late sign of dehydration. All right, so quality of pulses. Pulses might be nice and normal, or they could be a little bit decreased. You're probably going to see your peripheral pulses decreased just a little bit. So you would feel your pedal pulses, maybe your radial pulses, and see if they're just a little bit decreased. Breathing might be normal, might be a little bit elevated, okay? Just like with your heart rate increasing, so does your respiratory rate, because you're kind of trying to compensate. Your body will compensate with needing to get more of a acidotic versus alkalotic state. So it will do that through breathing out more CO2, okay? Eyes slightly sunken, or decreased amount of tears coming out when the infant or child cries. And a lot of times caregivers will tell you this. They'll say, well, she's been crying for an hour, but I just don't see any tears. That's a good sign for you to say, okay, she's probably dehydrated. Mouth and tongue are going to be dry. So what this really means when I say dry, I mean on the inside, those mucous membranes might be a little bit sticky, okay? And then on the outside, you might see some dryness of the lips. And then skin fold, we're going to see recoil in less than 2 seconds, but it's not necessarily going to be instant. We may see a little bit prolonged capillary refill. We shouldn't see more than 3 seconds, okay? And then extremities might be cool, urine output might be decreased. Why would their extremities be cool? We might also see just a little bit of mottling as it gets more severe, but because as children have poor perfusion, their extremities will get cool. And one of the things that your body does whenever you are a little dehydrated is it sucks all the water from the long extremities in your body and the peripheral areas, and it takes it to the inside central part of your body so that your heart can pump and get all of the vital organs nicely treated with perfusion instead of your extremities. Okay. Now, these mild to moderate kids do need monitoring that's closer. They will probably need a follow-up the next day. Definitely a follow-up by phone call if you're not seeing them in the office, and you want to have a really good clear plan for the caregiver to establish rehydration for that child. Any child that hits this severe, greater than 9% body weight loss, or any of these severe symptoms really needs to be reviewed or evaluated by a tertiary care center, okay? Because this isn't something that you likely will be able to manage in primary care and will more than likely need, like an IV fluid bolus or something that you cannot do in a primary care setting, okay? So they're going to be lethargic, possibly unconscious, okay? That right there should be a red flag to you to call 911. Poor drinking or unable to drink, okay? Tachycardic. And just like I said, guys, bradycardic in severe cases, bradycardia is a late sign of dehydration, okay? That's when your body is really going into a decompensated possible hypovolemic shock. Weak, thready, or impalpable pulses. Breathing is going to be deep, maybe almost Kussmaul type, okay? Deeply sunken eyes. Okay, I have a really good picture of this in a little pumpkin. Where did that go? Here we go. So this little baby definitely has severe dehydration. You can see he's probably about 1 year old. And as you lose fluid, the below the eyes in children will get very dark and they will sink in where they would normally have some fluid and be nice and robust and pink up under the eyes here. Okay. Absent tears, okay, not just decreased, but not there at all. Parched mouth, okay, parched. So that means majorly dry and cracked lips. So here's a little baby that has some parched lips, okay. That's very dry, and that is an infant. You may also see some breaking of the lip skin here. When you feel the inside of the mouth, and you would do that with gloves, but you're really not going to feel a whole lot of wet mucous membrane. It's going to be dry, maybe still sticky, but it's definitely not going to be moist. Next, you would definitely see issues in recoil of the skin. Turgor would be poor. Okay, capillary refill may be as high as 5 seconds, maybe even more, hopefully not. But if your capillary refill is starting to look bad in an infant, that is an emergency sign, and that means that their perfusion is poor. Okay, same thing with cold mottled appearance. Cyanotic, an emergency for sure. I know you guys already know that. Most likely you're not going to be seeing an unconscious cyanotic dehydrated baby or child in primary care. More than likely these infants or children would have already gone to the emergency room, but it is important for you to know. And then they may actually be anuric or absolutely minimal urine output. Another thing I wanted to show you as far as picture goes is if you don't have pediatric experience, a sunken fontanelle is something we see sometimes in children who are really dehydrated. So what it kind of looks like, so a fontanelle here, this is an infant, probably around the age of between 1 and 2 months, and this is the anterior fontanelle, and normally it is kind of like a little kite or diamond shape, but it's normally nice and pumped up and filled with fluid because an infant is well hydrated. It's soft, but it should not be sunken like this. So if you have the top of a baby's head that looks like an empty lake or pond, that would be a sunken fontanelle, and that is dangerous. Okay, that could be a sign of actual dehydration. If the child otherwise appears fine, sometimes I do see fontanelles that are a little bit sunken with no dehydration going on, but it is certainly something you want to evaluate. In a child who has vomiting, diarrhea, or other symptoms that would lead to dehydration, this definitely needs to be referred out because that's a late stage. Okay, so how are we going to manage dehydration in primary care? All right. If it's minimal or none, okay, so we just talked about the stages, then you're probably not going to have to do any kind of rehydration therapy, okay? But you do want to maintain that liquid intake for them. And there's a really good little formula here for you, okay? So if they're between 0 and 10 kilos, you're going to make sure that they get about 100 milliliters per kilo per 24 hours, and then so on, moving down from 10 to 20 to greater than 20. This is an excellent little formula for you to just make sure you write down and take with you into practice if you are working with children. Okay, replacement of ongoing losses is different. Okay, when you're actually replacing or rehydrating a child, it's different than if you're just maintaining. Okay, so sorry, just lost my place here. So for mild to moderate oral rehydration solutions, you're going to do 50 to 100 milliliters per kilo body weight over 3 to 4 hours, or 10 to 20 milliliters per kilo per hour. Okay, so that's the rehydration that you would do for that moderate, okay, and mild. Same maintenance, okay, same replacement of ongoing losses. Severe, obviously, if you're moving into IV fluids, you're not going to be doing this, right? Because we're primary care nurse practitioners, and we would want to make sure that if a child is in severe dehydration, that you are moving them on to a tertiary care center that actually can manage them better than you can. All right, move all of these over since we've already gone over them. Okay. Next thing I want to talk about is gastroesophageal reflux disease. Okay, so as I was telling you earlier, that there is a difference between GERD and GER, okay? So it's really essential for you to kind of get a good idea of what is the difference between GER and GERD. And right off the bat, I can tell you that any child who has gastroesophageal reflux, it's going to be what we call kind of a happy spitter. They're not going to be losing weight. They may be, irritable sometimes, but for the most part, they're a happy baby, okay, or child. They are not experiencing significant episodes of pain associated with their reflux. So in a baby, they may be experiencing pain after or with feedings and have outbursts of crying during feeds that the parents can't understand. Or a young child may tell you that their belly hurts and cry while they're eating or after they're eating from their GERD. The other things that you would see is, again, no weight loss, okay? They're not going to have any fluid loss. They're not going to be dehydrated. And their spitting up is not going to be severe. So although the parents may say, oh my gosh, she spits up all the time, it's not going to be something that really accounts for the entire feed of the infant or the child, okay? So things that you might see on history, you want to talk about what the feeding frequency is, what kind of formula or milk the child's on. Okay, actually, I do this all the time. You want to observe a child during a feeding. Okay, I have a parent come in for a feeding issue. If they haven't eaten yet and they're due to eat, I'll say, feed them right now. Let me take a look while we collect history. And a lot of times you'll see that child have a reflux episode if they actually do have a complicated GERD going on. Okay? Is there any kind of choking going on or gagging when the child is feeding? What does the vomiting look like? Okay, are they forcefully vomiting? Is it associated with any fever or diarrhea? Is it bloody or bile or bilious? If it's bloody or bilious, it's not just GERD. Okay, if it's associated with a fever and diarrhea, that's not just GERD. Okay, so the presence or absence of certain kinds of positives and negatives can really help you make your diagnosis. So getting a good history and physical exam is essential. All right, so does the child have any other chronic conditions? Were they premature? Growth and development okay? If you look at this infant's growth chart and you see that we're just falling off the charts and the mother or father or other caregiver is reporting, major spitting up, vomiting, seeming like the patient has got pain during the episodes, that is possibly a gastroesophageal reflux disease. It could certainly be other things that you would need to rule out that you would include on your differential diagnosis list, but it needs to be there. And if you see a child who has got poor weight gain or weight issues with falling off the growth chart, that's definitely something you would consider in your differential list. Okay, so next, we'll talk in a child who has regurgitation or vomiting. There are some symptoms that we look at that are kind of red flag, okay? Warning like, okay, this is definitely an issue that requires immediate or pretty soon urgency or attention. Any child who has bilious vomiting, that child could have some kind of an obstruction or perforation and needs to be seen immediately. That is not something you can manage in primary care. Same thing with GI bleeding, okay? Hematemesis or hematochezia. Hematochezia isn't necessarily a emergency that needs referral to the hospital. We do sometimes see bloody stools, which is basically what hematochezia is. We do sometimes see bloody stools in infants who have other conditions that can be managed fine in primary care, such as cow's milk protein allergy. And we will talk a little bit more about that a little bit later. Are they forcefully vomiting? We just talked about pyloric stenosis, okay? Is it consistently forceful, or was the vomiting at the onset of vomiting after 6 months of age? Okay, that's also something you would look at as a little bit more concerning than an infant who's been spitting since they were very young. Does the child additionally have failure to thrive? So a child who has failure to thrive is not just small, okay? They are failing to move across an adequate growth curve, meaning they're coming off the growth chart. They are not gaining weight or gaining percentiles in weight, okay, or body mass index. Recurrent respiratory infections. That's something to look at because recurrent respiratory infections in accompany with vomiting. What are you thinking about there? Possibly aspiration, right? So if you have a kiddo who's vomiting a lot and also having recurrent respiratory infections, they may actually be aspirating, and that's something that needs to be investigated further. Feeding problems, diarrhea or constipation, fever or lethargy, okay? Fever with lethargy and vomiting is not GERD, guys. Okay, if you have a child who comes in with fever, that is likely going to be, especially fever and vomiting, that's likely going to be related to infection or some other kind of major illness, and you need to work that out more. Hepatosplenomegaly. No child who just has GERD is going to have a swollen liver or a swollen spleen, all right? So that's something for you to consider wholeheartedly. Bulging fontanelles, macrocephaly or microcephaly. A child who has vomiting and bulging fontanelles or macrocephaly or microcephaly may have an actual neurological cause for their vomiting. Okay, so when you think of bulging fontanelles or macrocephaly, one of the things we think about in children is hydrocephalus. Okay, and on the growth chart, you may see that that child has a very elevated head circumference percentile. And I don't just mean it's in the 98th percentile. I mean, we would see a persistent elevation and off the growth chart percentile for head circumference, because some kids, some babies even, will just have big heads. They have congenital macrocephaly from their mom or their dad, and if they're staying on their growth curve of a 95th percentile head circumference, I'm okay with that. All right? As long as they're staying on that curve and they don't pop from the 70th to the 90th to the 95th to the greater than 90th and 99th all the way up from their 0 to 6 month visit, okay? Or from any other period of time in their life. Next, seizures. Child who's got vomiting and seizures definitely needs to be considered for a neurological cause. And then abdominal tenderness and distension. Babies who have GERD sometimes can bloat a little bit, but you are not going to see true abdominal distension or tenderness, okay? Children can tell you if their baby is or their belly is tender. Infants tend to guard, so when you palpate their abdomen, they'll pull their legs up really far up. They'll squeeze in their arms and they will wail out a little cry. And they may be having some persistent crying after you do that because it hurts them. And that is a good way that you can assess whether or not a baby has abdominal pain. In addition to, the parent will just tell you, he will not stop crying. I don't know what's going on, but I can't get him to stop crying. Any mom or dad or caregiver of any kind that comes in to see you and says, this baby will not stop crying, it will not stop, you need to consider pain as the reason for the cry, and you need to work that infant up a lot, because infants only have a couple ways to let us know something's going on with them. So crying is one of their natural born ways to tell us something is wrong. And if feeding and changing a diaper and sleeping and holding are not comforting that infant and they're still crying, then pain may be associated and that infant needs worked up. Okay, so some of the common medications that we would see treated for GERD. Okay, and again, this is GERD, not gastroesophageal reflux, but reflux disease. So the infant or child is coming in to see you with, spitting up or vomiting, possibly some weight loss or poor weight gain. They are having, painful episodes with feedings or during feedings or after feedings. We sometimes call it Sandifer syndrome in infants, and I'm going to pull this picture up here. This little reflux here, when you see a baby who feeds and frequently arches their back like that, especially during or after feeds, this is a way for them to compensate for pain as it goes up their esophagus. So they will attempt to elongate their body in order to decrease that pain as it comes up in the esophagus, and they may scream and cry at the same time. Okay, so make sure you talk to the parents about what kinds of body movements the infant and children are making. Are they making those kinds of arching if it's an infant, or is the child talking to them about pain? Okay, so common medications that we would see, cimetidine. Okay, that's one of the probably the least commonly ordered, I would say, in practice. One of the more common ones that you'd order right off the bat would be Zantac. Okay, so famotidine, nizatidine, and then ranitidine are the three more common medications and first-line therapy for children that you think have gastroesophageal reflux disease. Okay. In a child who has GERD and associated with weight loss and severe pain, you may actually move right on to a proton pump inhibitor for them, because these two medications are excellent, but they do different things. Okay, so where the first group here, the histamine antagonist, that's going to decrease the acid in the stomach. Okay, it's going to decrease that histamine 2 release, and it's going to kind of neutralize the stomach with acid, which really helps when they actually are still spitting up, because it's not going to do anything for their spitting up if you give them an H2 blocker. Okay, they'll still spit up, but what will happen is it will be less acidic, so it will be less causing of esophagitis, and it'll be less painful because the stomach contents are going to be more neutralized. Okay, so it's not really going to do anything for your severe vomiting kids who are having weight loss associated with GERD, in which case you would want to try to help them with this. And with your proton pump inhibitors, you actually can see some decrease in the spitting up and vomiting episodes. Okay, so but for younger children or infants that you're going to start off with an H2 blocker, these are probably your three most common. Zantac tends to be first line. Any one of these would be appropriate depending on the child's history and allergies. Okay. For the purposes of your testing, again, I'm not going to ask doses, but I do want to know that you know that an H2 antagonist is going to be your first line for a child who's not losing weight and does not have severe pathology with GERD. So for those kiddos who do have severe pathology with GERD and likely need starting with a proton pump inhibitor, let's see if I can get, I'm going to draw a little picture here. Where can I draw that? Actually, I probably could draw it right on here. Okay, so your stomach's back behind here. Draw a little. I'm not an artist, so just keep that in mind. Okay, so imagine that this is a stomach, okay? The way that a proton pump inhibitor works, if you give it while the child has got something to eat on their belly, it will do nothing, okay? So what you want to do is make sure that you educate the caregivers about giving this medication, a proton pump inhibitor, so that means any one of these, Prevacid, Prilosec, Acifex, Protonix, or Nexium. Okay, you want to educate them that this medication has to be given before the child eats. Okay, so the medication goes down in here to the belly, and on the stomach, it actually sticks to the proton pumps. It grabs a hold of those proton pumps in the stomach lining, and it blocks them from releasing that, or inhibits them from releasing those proton pumps. And it's essential that you give it while their tummy has nothing in there, because if not, this medication isn't going to be able to get to those proton pumps and block them from secretion. So you must make sure that you educate 20 to 30 minutes before a meal is when that medication can be given. That way you will properly have that medication in the stomach and blocking those pumps. And a proton pump inhibitor is really not cheap, and it's over the counter. And a lot of times if parents are paying for this themselves, if they find out that for a month they've been giving the medication wrong, it's really kind of a bummer to them, and they will be frustrated. So make sure you're giving good education that proton pumps should be given before meals, 20 to 30 minutes usually. Same thing with your Zantac. You do want to give that 10 to 15 minutes before a feed. All these GERD meds are before feeds, but proton pump inhibitors especially should always be given before feeds. All right, so one last thing I wanted to talk to you about proton pumps inhibitors is the length of time that you keep them on this management. You really want to not go longer than 6 months without referring to a GI, okay? Typically 12 to 16 weeks is kind of where you're saying, okay, let's take a time off and we'll recheck you and see if taking that time off of your proton pump inhibitor is okay, or if you come off that proton pump inhibitor and you're still having severe symptoms or you're still having a lot of pain, then we need to think about referring you to a gastroenterologist, okay? Your more common medications here is going to be your Prilosec and your Prevacid, but I have prescribed both Protonix and Nexium before. Acifex is one that I use a lot less commonly. In fact, I don't think I've ever used that. Carafate can be used to treat gastroesophageal reflux disease. However, it's really more commonly used in peptic ulcer disease, okay? So Carafate is a wonderful drug that really helps, but it is also something that shouldn't be given unless it's needed, okay? The way that Carafate works is it breaks up in the stomach into this little slurry, attaches onto the areas like ulcers and esophagitis or gastritis areas, kind of creates like a nice little coating so that the acid does not hit it. It really helps to decrease pain in kids who have severe GERD and GERD that's associated with peptic ulcers or even duodenal ulcers. But it's not something that you're going to be giving a whole lot of in primary care just for GERD. Again, we use that more commonly in peptic ulcer disease. All right, moving right along here. So I wanted to kind of go over this algorithm with you because it's a really nice little quick algorithm that will help you make a decision in management for children who have vomiting or regurgitation with poor weight gain, okay? So again, consider these three things have to be present. If you have an infant that comes in with vomiting and regurgitation, okay, so those two things are different. Vomiting, they may actually be vomiting their whole feet up. Regurgitation may just kind of be like a little, you may not be able to hear that very good, but they may be kind of regurgitating, but you can't necessarily see it. In fact, some of my worst patients with GERD are regurgitating a lot without spitting up, but they're just regurgitating right into their esophagus and it's not actually coming out of their mouth. That doesn't mean that they're not regurgitating just because they don't vomit out of their mouth. So vomiting, regurgitation, and poor weight gain. Let's look at this algorithm. You want to make sure you're getting a great history in PE, okay? Are there warning signs? So we talked about what the red flags were. If there are warning signs or red flags, the infant's not gaining weight, okay, or the infant's having Sandifer syndrome, they're having, more pain, you need to evaluate further and consider medications. Are they having adequate caloric intake? If not, that is another thing that is good to focus on because they may just have issues with their caloric intake, okay? If they're just not having adequate caloric intake, they may need really good education for you to talk to them about getting more calories into their diet, okay? And some gastroesophageal reflux education, but not necessarily medication. If they are getting adequate calories, okay, so the mom says, no, he eats a ton, we're eating a lot, then you really want to consider a workup for failure to thrive, okay, possibly an upper GI series. Is that abnormal? If no, then you want to consider dietary management. You want to consider a different formula, okay, possibly a hydrolyzed formula, okay, thickened feedings. You want to talk about increasing caloric density. Is that improved once you've added that management? If yes, then great. Education and close follow-up after you've done that dietary management, possibly changed formula, thickened feeds, and gotten more calories in that infant. If after you've done all of those things, you're still not seeing improvement, that's when you want to consider a pediatric gastrointestinal specialist, consider acid suppression therapy, and hospitalization would obviously be reserved for severe cases of failure to thrive, GERD, not something you're going to be doing most likely in primary care. All right. So the next thing I wanted to go over, sorry, losing my place here. I know I had some management here. Okay, so signs and symptoms of GERD that you're going to see infants or children come in with. Again, we talked a little bit about this, but irritability, choking, arching, gagging, feeding aversion, okay? Kids who have severe GERD are not going to they're hungry, but they're hurting, so they're not necessarily going to want to eat, okay? Because they may have esophagitis, all right? Usually symptoms resolve between 12 and 24 months when it comes to GERD. Once they start getting upright and walking a lot more, then they're going to have less symptoms of GERD than they would as they get, as when they're younger. Okay, stridor or lower airway disease. Okay, sometimes we see kids who have laryngeal or tracheal malacia, and those kids will almost always have concomitant GERD. It's just kind of like a rite of passage. If you have a child who has laryngeal or tracheal malacia and the caregivers talk to you about new onset spitting up, you definitely want to think about working that child up or considering a good thorough history and exam for gastroesophageal reflux disease, because the narrowing of the larynx or trachea can contribute to worsening gastroesophageal reflux. Child and adolescent. So they're a little bit different. They will still have regurgitation during their preschool age, but they'll have abdominal pain and chest pain. Kind of that chest where the heartburn would occur. Okay, not the chest pain that you would be concerned about for, cardiac causes or for musculoskeletal causes, but it's really more associated with like a kind of, they'll describe it as burning or ouchy feeling, okay? Arching or turning of the head a lot during feeds or after to make them feel better, stretching out of their neck, okay, neck contortions. And then children who have asthma, allergies, sinuses, and laryngitis or chronic laryngitis will also have an increased risk and GERD. All right. So let's go on to peptic ulcer disease. So peptic ulcer disease is really kind of a group of disorders, okay? It's a group of gastric and duodenal disorders ranging from gastritis to ulceration. So is their tummy, is their stomach just inflamed and, kind of agitated, or is there an actual ulceration present in the stomach? Those two things are different. And then with duodenal ulcers, mucosal defects penetrate the duodenal mucosa and submucosa, okay? So there's a small intestine ulcer and then there is a stomach ulcer. And the differences in those two can really usually be seen in pain and then onset and the presence of vomiting. Typically with peptic ulcers or stomach ulcers, you'll see more vomiting than with a duodenal ulcer, okay? And with a duodenal ulcer, eating will actually make the pain worse. If you have a patient who has an ulcer in their small intestine, they may tell you that with feeds within the hour of eating that they're hurting more, okay? It's not common for infants to have duodenal ulcers, so I'm talking a little bit more about older children. But in peptic ulcers, kids who eat hurt less, usually, unless it's really advanced stage ulcer that is close to perforation, which you hope that you're not that far in. And the reason is, if you think about the nature of what sits inside of a stomach, it's full of acid, okay, and it's full of chyme, and when it's empty, that ulcer is just sitting there with that acid to be agitated. So a lot of times these kids will wake up with belly pain in the middle of the night when they haven't eaten in a long time because their stomach is sitting without anything on it. Or they'll tell you, or the caregiver will tell you, he has belly pain every morning when he wakes up, okay? In addition to other symptoms, of course, not just the I don't want to go to school type of functional abdominal pain. This is real severe type of pain. But once they eat, they may feel a little bit better because putting food on the stomach actually decreases the acidity in the stomach and can also decrease the pain with the ulcer. Okay? So, are they having pain with eating, dyspepsia, waking from sleep, okay? Poor feeding, GI bleeding, vomiting. Toddlers in preschool areas may have some localized belly pain or vomiting and GI bleeding. It actually may worsen after eating in little younger ones. Okay, school-age children and adolescents have kind of a generalized epigastric or right above that epigastric area or right lower quadrant pain, which can sometimes alert you to think that it might be an appendicitis, but an appendicitis is a totally different acute abdomen appearance, and we'll talk a little bit more about that in a bit. So the pain's often described as kind of dull, aching, and maybe minutes to hours. It's definitely not comfortable, for sure, okay? Things that might predispose it, alcohol, smoking, NSAIDs for sure, if they're on steroids, stress, okay, emotional and physical stress, okay, other obvious physical conditions will make that worse. If the child is a young child, obviously doesn't smoke, but they are exposed to smoke, secondhand smoke can also worsen that. For physical exam, you want to take a good look at the child. You want to see if they're perfusing well. You want to take a look at their hydration. Good inspection of the mouth, okay? Do they have ulcers in their mouth? And can you see esophagitis in their throat? Okay, don't always think that every esophagitis you see is from a sore throat, from an infection. I see esophagitis a lot that's related to, apnea or sleep issues at night, or esophagitis that is related to gastroesophageal reflux disease. That's not uncommon. Okay. Moving right along here. Let's see, where did I put that? Here we go. Okay, so one of the things that is actually common to cause an ulcer is called Helicobacter pylori. And H. pylori is a bacterial infection that can exist in the gut. So if you have a kid with peptic ulcer disease, one of the things you definitely will be considering testing for is H. pylori. Now, these kids may have already been seen by a gastroenterologist and being worked up by a gastroenterologist. That's okay. You wouldn't necessarily be the one always ordering it, but if you have a child who comes to see you with abdominal pain, maybe intermittent, non-severe vomiting, kind of vague symptoms, and you test them for H. pylori and that comes back positive, these are some things that treatment plans that you are going to be considering, okay? There's 3 options for treating it. And a lot of it has to do with the age group and then also what allergies the child may have, okay? So it's not a simple treatment regimen. It has to be treated with a few things in order for it to be eradicated. But you can treat with a combination of amoxicillin, clarithromycin, and Prilosec or omeprazole, okay? Or amoxicillin, Flagyl, and omeprazole. A lot of times this needs like anywhere from 2 to 4 weeks of treatment. Sometimes you can get away with 2 weeks, but I'm usually giving this to them for upwards of 4 weeks. And it does help sometimes when you are thinking about how long to do the therapy to consult with a gastroenterologist to see how long they think that it would be good for you to do it. Okay. The other option is bismuth subsalicylate. Okay, now you want to make sure that this is a child who is 8 to 12 years old. You want to make sure that it is a child that is definitely not positive for flu, definitely not got chickenpox. Okay, because the chickenpox and flu, if you give a child aspirin while the child has chickenpox or flu, you can give them Rye syndrome, which can kill them. And it's essentially a syndrome that only children get that leads to swelling of their brain. So again, bismuth subsalicylate, amoxicillin, and metronidazole. And then sequential therapy with just omeprazole and amoxicillin for 5 days, then omeprazole, clarithromycin, and metronidazole for 5 days. Again, typical therapy is about 2 weeks. Sometimes I have had to treat them for up to 4 weeks, but if you have questions about that, you can actually call and talk with a gastroenterologist. Now, remember that anytime you give a child a bunch of antibiotics, what are they going to be at risk for? Yeast. So start off with the 2-week therapy, okay? And if they end up needing referral after that, you certainly can. Okay, moving right along still here. Let's talk a little bit about, where did it go? Here we go. Infant colic. Oh boy, do I feel bad for the poor babies who have infant colic, but you know who else I really feel bad for? Their parents. All these poor babies. They cry all the time. In fact, the diagnosis is made in younger than 3 months, cries for 3 hours or more a day for at least 3 days per week. And it may actually in reality only be that much, but a caregiver is going to describe it as much more. Now, 3 hours or more, this needs to be consistent, okay? So it can't be 30 minutes here, 20 minutes there, 15 minutes there for a total of 3 hours in a day. It should be persistent crying and screaming for 3 hours or more, okay? For 3 days or more per week out of the week, and they have to at least be 3 months of age or younger, okay? So demands frequent feedings, often fussy. The caregivers will describe to you that they just cannot console them. Excessive gas, inconsolable sometimes for, not being able to be comfort, tight, tense tummy, pulling up the legs, clenching of the fists, frequently agitated. Okay, so red flags in this history would be things like apnea, cyanosis, struggling to breathe, excessive spitting up or vomiting. Because what are we thinking about there? Possibly an associated GERD, right? So, but if they don't have or if they have the absence of red flags and they only have these things up here, possibly with some physical exam characteristics, then you may actually be dealing with diagnosis of colic, okay? If possible, see the family during a crying time, okay? Tell the family to call you back if they call to make an appointment with the nurse, tell your nurses, Tell them to bring them in during the crying time, because you want to see them during that crying time. You want to see what their abdominal muscles are doing. You want to see what their legs are doing. You want to see how inconsolable they are. Okay? Full body examination to take a look at trauma or abuse is actually necessary, because what did we just talk about? Infants who come in with pain, that is the only thing that they can communicate to us with. So if they have had trauma, they may be screaming or crying from that trauma and related to pain. So you want to make sure you do a good examination of their body. And then also stool for blood or mucus is something you can consider, because sometimes infants who have colicky symptoms will actually have a cow's milk protein allergy. And we're still going to be getting into that discussion in a little bit, but it's important for you to weigh out other physiologic causes before making a diagnosis of colic. Okay, so you want to make sure that you've done a real good workup on these babies before passing them off as a colic diagnosis, because really there's no excellent treatment for colic. Okay, the goal of the treatment is really to manage the colic until it resolves itself. Typically will resolve by the age of about 6 months. When you tell a parent that, though, they look at you with this look of, you've got to be kidding me that there is nothing else that you can do. Because a lot of times they are sleepless, they are exhausted, they need a break, and they need you to fix it. So you never want to say things like, well, there's no treatment. That will just really burn their bridges and make them feel horrible. So you want to tell them about the things there are evidence for, okay? So let's talk a little bit about that. Close these out here. Okay, so elimination of certain foods, okay, if the baby is breastfeeding, may be beneficial. The first things you're going to start with are cow's milk products, eggs, peanuts, tree nuts, wheat, soy, and fish. Okay, and you don't have to make the mother take away all of those at once, but that would be a good 2 weeks or so of elimination. Okay, so mom, try milk for a good 3 to 5 days. If you see a difference in the baby's demeanor, excellent. Just stay off milk. If that doesn't seem to help, try eggs or peanuts or tree nuts or whatever the mom is that may be eating a lot, okay? Hydrolyzed formulas actually can show some effectiveness in treatment of infants with colic, okay? We don't really necessarily know why, but a lot of infants with colic type or colicky type of pain may be experiencing significant abdominal pain related to a difference in the way that they absorb and digest their food. Now, the unfortunate part of this is if you have an infant who has colic and they have a difficulty affording expensive things and they do not have WIC and they cannot get approved for WIC, the parent would have to pay for that hydrolyzed formula. Hydrolyzed formula is expensive, guys. Okay, so our hydrolyzed formulas are going to be things like Alimentum and Nutramigen, okay, Neocate, and they are not cheap. I'm talking $35 to $40 per can, and a can lasts an infant who's around the age of 1 to 2 months, maybe 3 to 5 days, okay? So consider the cost and try the things that are not super expensive as therapy first. You want to provide lots of education, okay? That's an excellent way to help affirm that the mother or father or caregiver, that they're being heard, that you know it's a problem and you know how hard it is and that you can empathize with them. Okay, give them soothing techniques, encouraging suckling at the breast, fist, fingers, or pacifier. That's okay, because the baby's not always going to want to eat, but they may want to suck because that's comforting to some babies. Swaddling can be very comforting in infants, okay? It improves sleep and shortens periods of distress. Have them swaddle. Teach them a good swaddle technique if they're not doing that. Sometimes white noise, lullabies, or shushing, recorded mother or recorded maternal sounds. Recording of a mother's voice has actually been shown to improve help with colic and also decrease pain in the NICU. So you can tell the mother that she can make like a little recorded audio or video of herself and put it at the bedside just talking to the baby. That might help as well if the mom just needs some downtime or dad needs some downtime. Kangaroo care, so skin to skin. Car rides. Oh my goodness, some babies just love some car rides. In fact, one of my sons was like that, and I swear it felt like every night we were taking him for a car ride. And my husband would be like, I'm going for a car ride, and I'd be like, okay, I'll sleep while you go. And then we would switch off because one of our sons just sometimes would cry so long, and the car would put him right to sleep. All right, so complementary therapies are also important for you to know about in order to talk with your caregivers. Probiotics have been shown to improve some episodes or length of crying. That's why Good Start Soothe, okay, and also I think Similac Total Comfort, they're both purple cans, have been shown to decrease crying time and have been shown to increase or help with colic. There's also something out there that is Gerber Soothe drops. Okay, and there are other probiotic drops, but just like your hydrolyzed formula, they are super expensive. And I mean like $24 for a teeny tiny bottle that might last a couple weeks. So for your families who are on fixed incomes or who might not be able to afford that, that would be a difficult therapy for you to recommend for them to get. But it's important for you to know all of the therapies out there. Certainly sucrose solutions might help infants with pain times, but we worry about actually increasing babies' blood sugars with giving them too much of that. So that's not something you want to recommend often. And then chiropractic or other homeopathic remedies are available and certainly something for the caregivers to consider, but you want to make sure that they are going to an actual practitioner who has experience in pediatrics or infants and knows what they are doing, because obviously there can be risks to the infant's and child's safety. All right. Moving on from colic. So let's talk a little bit about appendicitis. Let's see if I can pull out these things up. Okay, so appendicitis and an acute abdomen in general is something that's pretty scary in primary care for new nurse practitioners. So don't feel like if that's something that makes you go, woo, that that's abnormal. It's not, okay? And it's always going to be on your differential list when you see somebody with abdominal pain, whether it's an adult or whether it's a child. It is going to be ingrained in your head that appendicitis should be on that list, okay? But the best thing for you to do with appendicitis for an actual diagnosis of a dangerous acute abdomen is going to be a thorough history and a good physical exam, okay? So the most reliable information is gained from a sequence of symptoms. So for appendicitis, pain initially is poorly defined in kind of the periumbilical area, and then acute onset of pain is not really typical. Okay, so if you were to see a kid that came in 3 hours ago starting with really horrible pain in the right lower quadrant, that would be less typical of appendicitis than a kid who said that yesterday and the day before they started with some belly kind of generalized to their belly button area and it's moved or migrated down to the right lower quadrant. Okay, that's more common. These kids will have nausea and vomiting. Okay, typically occurs after the pain. Alrighty, anorexia. They do not want to eat, okay? 50% of children do say that they're hungry, but they know they're not going to eat because it will make him want to throw up. Stool is probably lower in volume and does have a little bit more mucus because they're likely having issues with malabsorption. Anytime you see stool with mucus, you want to think malabsorption issue, okay? Malabsorption, malabsorption, malabsorption when you see mucus in a stool. It doesn't necessarily mean there is a chronic issue. Could just be they've got like a little gastroenteritis going on or they ate something they shouldn't have. But if it's persistent stool with mucus, then that is something that needs to be considered for malabsorption issues. Fever is not sensitive or specific for appendicitis, okay? A lot of kids will come in with appendicitis and have no fever at all. So you want to make sure that if they do have fever, that is more associated with a perforation or a burst appendix, and that's dangerous, okay? So if the kid has high fever with their right lower quadrant pain, there's a possibility they've already ruptured their appendix and they need to go to a tertiary care center. Okay, so there also is a scoring system here, okay? Nausea, focal right lower quadrant pain, migration of the pain, if they have difficulty walking. Rebound tenderness is very sensitive for appendicitis. Okay, so that's basically where you're putting your fingers on the abdomen, pushing in quite deep and lifting up. If there's pain after you lift your fingers, that's rebound tenderness. Okay, A and C, you're not necessarily in primary care going to have the ability to get an absolute neutrophil count. You may be able to get a CBC and see an elevated white blood cell count. That is something that would be more indicative of appendicitis in the presence of these additional clinical manifestations. Okay, so a complete physical exam is important when you have a kid that you think may have appendicitis, okay? Guarding. These kids are not going to be sitting up and talking to you. They're going to be laying down, probably in a ball, holding onto their stomach, really hurting bad, okay? Heel drop jarring test is something that you can do on the kids, but I honestly think, and it is evidence-based, that a psoas sign is going to be something that is most positive, or the obturator sign is going to be most sensitive for diagnosing the presence of appendicitis. And I do have a little video that I'm going to bring over here so that you can see. Please pardon the acting. She's by no means a Goldie Hawn, but let's take a look because it is a good elicit.
Psoas sign is another indicator of acute appendicitis. The appendix lies close to the iliopsoas muscle, so if the appendix is inflamed, any maneuver that tenses or stretches the iliopsoas muscle may result in increased right lower quadrant pain. There are two ways to test this psoas sign. One way is to have the patient try to flex the right hip by raising the right leg against the resistance of your hand. Tom, I'm going to have you raise your right leg against my resistance and let me know if you have any pain. The second way to test the psoas sign is to have the patient roll onto his left side, then grasp the right leg and extend it at the hip. This stretches the psoas muscle. Increased right lower quadrant pain with either of these maneuvers is a positive psoas sign. Tom, I'm going to have you roll on your left side. And I'm going to extend your leg and let me know if you have any pain with this. Okay. You can turn back over on your back.
Okay, so I will say that in a kid who has, and most adults who have appendicitis, they're going to be jumping off the table if you elicit a psoas sign. A positive psoas sign really hurts. So if you take a look, let's just pull that back up here. We'll actually play it again, but kind of when she was doing that examination, so right here, if you think about where your appendix is located, it's attached to that muscle. So both of those extensions, external rotations that she was doing are eliciting pain because it's pulling on that muscle that is very closely associated with the appendix, okay? So, but again, that really causes a lot of pain, and so if you do elicit a positive psoas sign, those children are not going to be just kind of pointing to the pain the way he did in the video. They're probably going to go, ow! Or they're going to really give you like a nice little jump to let you know how painful that is. They may even cry after you elicit a positive psoas sign. Okay, so some of the tests that you may do if you're thinking a child has appendicitis are going to be listed here. But I'm going to tell you, I tend to be very conservative with my management of things. If I think I'm going to have a child with appendicitis, I'm pretty much have my diagnosis before I'm even sending them on to get a CT, okay? And so I am not going to order a CT for questionable appendicitis. You should definitely know, I think, for sure this kid has an appendicitis before you're ordering an expensive test like that. Because an abdominal ultrasound can actually show or actually help with the diagnosis of appendicitis. It's not as good as a CT, but it's less expensive and it actually can show in some cases an appendicitis. Additionally, an abdominal radiograph actually can show a fecalith or an appendicolith, and basically that's a stone inside the appendix that could be associated with an appendicitis, and that would also be another thing that would let you know that you could have an appendix that's inflamed and swollen. All right, so rule of thumb, if you really think that a child has appendicitis, kind of probably the best decision to make there is to refer them on to tertiary care to be evaluated, but not just if they come in to see you with abdominal pain, okay? You want to do a really good workup if all the child has is abdominal pain. I'm talking about the presence of these things on history and these things on physical exam would definitely be a reason for you to refer for admission to the hospital. All right. So next, got appendicitis. Okay, so let's talk about, wrong one, that's chronic, let's do acute. Let's talk about kind of a little decision tree for acute abdominal pain, okay? So acute abdominal pain is, like we just discussed, can be something that's pretty scary for a practitioner. And that's okay, that's normal. But this little decision tree in your burns book can kind of help you give an idea of where should I go next. Okay, so we start with, is there evidence of trauma? If there's no evidence of trauma, you're going to be looking at whether or not there's fever. If there's evidence of trauma, then you're going to be looking at a child abuse issue or accidental issue. Okay, accidental injury. That does happen. In fact, the number one cause of death in children is accident or preventative death. Please, I'm going to say that again. It's so sad. The number one cause of death in children is accidental or preventative. Okay? Doesn't necessarily mean that the caregivers are just poor parents. It just means that kids are accidental by nature. They do a lot of things. They are active. They move around. They want to explore. They are super curious, like Curious George. And because of that, if they are not constantly monitored, they are at risk for death. All right. So evidence of trauma not there. We're going to take a look at fever. Yes, if they have fever. Here's some good things for you to be thinking about. Let's take a look, possible urinary tract infection, okay? Strep pharyngitis. Kids with strep, okay, group A beta hemolytic strep actually often will have, in about 50% of cases, horrible abdominal pain, okay? Maybe gastroenteritis or another viral syndrome. Flu, okay? Influenza can present with yucky abdominal pain. Mesenteric lymphadenitis is going to be really the least common probably up here, but it is something you could be thinking about if all of these others are worked out of your differential list. Mononucleosis, okay, kids with mono will have abdominal pain sometimes because their spleen is inflamed or enlarged. Doesn't necessarily need to be enlarged if it's inflamed, but mononucleosis is a disease that does infect the lymphatic system, and it can make your spleen enlarge. So sometimes kiddos with mono will have belly pain. Pneumonia. Kids who have pneumonia cough a lot. So we often will see kids with pneumonia who have abdominal pain from coughing so much, their abdominal muscles will be painful, and also abdominal pain associated with the vomiting they have from tussive emesis. Okay, so next, no fever. Do they have evidence of sickle cell anemia? Okay, and that's simply because kids with sickle cell anemia can also present with acute abdomen or acute chest syndrome or acute pain in their abdomen. Okay, if no, then you would look at where the pain is. If yes, then you may think about sickle cell crisis. Okay, so let's keep moving. If they have left-sided pain, no, then you would be considering the pain is more right-sided. If they have left-sided pain, you're going to be thinking about the location of all those organs that we talked about, okay? Consider constipation or torsion of an ovary or testicle. I love this decision tree because it gives kind of a really good clear like arrows of where to go based on what's present and what's not, okay? So middle to right-sided pain. Positive? Here's what you're going to be thinking. Ovarian torsion, appendicitis, testicular torsion, middle schmerz. If you don't know what that is, we'll learn a little bit more about that in the GYN section, but you can look that up as well. If they do not have middle to right-sided pain, you may be thinking about what's present in other household contexts, okay? Is it possible that they got a virus from somebody else? Or is it possible that they have been poisoned with food? Are they sexually active? If yes, then we could consider sexually transmitted diseases. So you get the point here. I'm not necessarily going to go over the entire thing here, but the point is this decision tree is an excellent way for you to consider plans in your differential diagnosis and the presence or negatives, okay? So the positives and the negatives. The presence or the absence is what gives you and helps you with your diagnosis, guys. Pertinent positives and pertinent negatives leads to your critical decision making in your differential. That is how we make a diagnosis. History and physical exam. Again, I usually say this in every single lecture, but 80% of the time, if you have a really good history and physical exam, you're going to be right on your diagnosis the first time. So don't move too quickly with your patients. Really listen to them and do a good, thorough physical exam. Okay. So, moving on some here. Let's talk a little bit about, where did I see it? Here we go. Malabsorption issues. So malabsorption issues, the three main malabsorption issues that you're going to see in kids are going to be celiac disease, lactose intolerance, and then cow's milk protein allergy. Okay, and these will range a little bit in the ages that you see them present. Alrighty, but celiac disease, okay, let's kind of start back here. Celiac disease, the things you're going to be seeing with these kiddos is going to be diarrhea. Okay, they will definitely have abdominal pain. They may have intermittent diarrhea or chronic diarrhea, because they may actually know, okay, when I eat that, my tummy does not feel good, but they may not necessarily know it's related to a gluten or celiac cause. You could see nausea and vomiting, okay? Weight loss is certainly possible because their bowel is inflamed and not properly absorbing nutrients because of what's going on with the effects of the gluten in their gut, okay? And what we see a lot of times with celiac disease is that these healthy microvilli here, okay, everybody in their gut has microvilli, and the reason we have microvilli is because, oh my gosh, we can absorb so much more. If instead this was just flat, look how much more we can absorb if all of these microvilli are like this, right? So, but in a normal healthy gut, we see these microvilli nice and tall, nice and pink, and with good vasculature. In a child or an adult who has celiac disease, we see that these microvilli actually shrink, and they are affected by atrophy, okay? And they're really not healthy microvilli because the gluten is essentially a toxic type of enteropathy inside their gut, and it's making it hard for them to absorb nutrients and have normal digestive process. So, and let's move on just a little bit to talking about the diet, okay, for celiac. Celiac disease requires a strict gluten-free diet. Okay, that's for life. If a child has true celiac, they will have to be on a gluten-free diet for life. That's the only effective treatment for this disease. It is something that they will be on forever. All right? Now, please remember that having celiac disease and having somebody come in and tell you they're gluten intolerant is not the same thing. There may be cases of children or adults having gluten intolerance. The caregivers will tell you, well, he just feels better when he's off gluten. That doesn't necessarily mean that he has a gluten enteropathy. That is not the same thing, okay? So, this again, the standard treatment for celiac disease is going to be a gluten-free diet. Adding pure oats to a gluten-free diet can improve palatability and increase fiber intake, but oats do need to be watched because if they're not truly gluten-free, they may actually have barley, wheat, or rye in them. So oats must also be watched unless they have a statement or claim of being gluten-free. Okay, pure oats are gluten-free. Alternative treatments are being explored, but really right now there's not anything except a gluten-free diet as standard treatment. Lactose-free diet for young children may also be helpful. This is generally not the case in older kiddos, but or adults, because again, gluten-free diet is something that needs to be lived with for long-term management. Now, you may be like, well, what is gluten in? Okay, so gluten is found in wheat, barley, and rye, and it is in some oats that are not actually pure oats, okay? So if it is pure oats, then they can have it. Okay, so I like this little chart here. It's called the Yum Run gluten-free shopping list. I like it for patients. I don't necessarily like it for us unless, because for us I'd like something a little bit more detailed, but I'm showing it to you because you want to make sure that your patients and parents have access to something that they can really understand. Please don't try to give them a list of a bunch of things they're not going to understand. They need to be able to go to the grocery store and know, what can my child eat? Great. Here are the things your kid can eat. They can eat eggs, okay? They can eat butter. They can eat flaxseed. They can eat cheese. Yay, yum, I love me some cheese. Lots of kids do too. They can eat corn, fruits, potatoes. They can eat meats and fish. They can drink milk. They can have yeast, rice, veggies, yogurts, vanilla extract, okay? And the reason it's important for them to know what they can buy is because when you put somebody on a diet that is lifetime, you will never see a sadder face. Okay? Especially in a child who understands what you're telling them. If they're young enough, they don't necessarily understand. They might not be knowing what they're missing. But a child who's a little older, when you say, oh, by the way, you can no longer have bread. Imagine it, guys. To tell a child, or even you, if I told you that you could not have bread, you would be so sad, right? Now, there are gluten-free breads, okay? But most breads do have some form of wheat, barley, or rye in them, and you must get a gluten-free bread in order to be able to eat bread, okay? So these kids cannot have bran. They cannot have ramen noodles, okay? They cannot have flour tortillas. No beer unless it's specifically made with a gluten-free type of grain. No graham crackers, no soy, teriyaki sauce, no cake flours, no pasta. No pasta? They do have gluten-free pasta. I will tell you, it's rough to eat. I have eaten it before. But what I'm trying to get at is it's a rough diet to live by, just the same way that a diabetic would have issues with their diet. A cow's milk protein allergy would have issues not eating cow's milk, or a mom breastfeeding would have difficulty not eating cow's milk. Be sensitive and give lots of options, because one of the best ways to keep kids compliant with eating is to provide them lots of education, and caregivers lots of education for an exchange list, okay? They can't have this, but they can have this. No, you can't have cake flour, but mom might be able to make a different kind of cake, okay, with vanilla extract and something that has nuts and something that is made with yummy butter and eggs. So what I'm saying is really give them good information and education about what foods they can eat, because that will help them with your compliance. And there are a lot of really good resources listed in your textbook to give out to caregivers as well for celiac. Okay. So next, hang on, move my things over here. Sorry for the noise. All right, so the next thing I want to talk a little bit about is lactose intolerance. So for lactose intolerance, you're going to see abdominal pain, you might see diarrhea, nausea, lots of farting going on in these kiddos, okay, and stinky gas. The parents are going to be like, whew, his gas really smells. Bloating of the abdomen is also something that you might see. And in lactose intolerance, I know we talked a little bit about that pH and reducing substances. That's an inexpensive test that you might order to look at the presence of carbohydrate malabsorption. It's not something that's going to tell you definitely lactose intolerance, but it will help you to make your diagnosis in a less expensive type of way. And you can always try to do an elimination diet. And if you see improvement in elimination of lactose, or you have added lactate milk instead to the diet, and then you've got your diagnosis, guys, okay? So you want to avoid lactose-containing milk or other dairy products. Use lactose-free dairy products. There's lots of lactose-free products now, because lactose intolerance, the same with gluten-free products, has become prevalent, and people will use them because they need them for their health. So make sure that you are encouraging, if a child is diagnosed with lactose intolerance, encourage these caregivers to that their kids can still eat dairy, they just have to eat the lactose-free dairy. So what's going on in a child who has lactose intolerance is they actually are missing an enzyme that helps to break down lactose. Okay, so lactose, if it's not broken down, is not good. That's what's caused the nausea, the flatulence, the abdominal pain, the diarrhea. Your body needs lactase, which is that enzyme that breaks down the lactose, in order to digest and get it into basically a smaller chain that the body likes to actually get rid of and waste. So you can also take lactase pills. They do have lactase pills or lactase chews for your older kids, okay? But again, when you take a look at what these symptoms are, usually we're seeing lactose intolerance in your older kids. I have diagnosed it in infants, but it's not as common, okay? Infants who have lactose intolerance or issues with lactase and lactose may do really good, or milk intolerance may do really good on a soy formula, okay, which is very prevalent now. All right, so test to ensure the individual's actually lactose intolerance, okay? We already said what to do. oral lactase supplements like we just talked about. Okay, this is really a clinical diagnosis, guys. Elimination of lactose will make this situation better, okay? Or adding lactase to the diet will make this situation better. So if you do that elimination diet and the child has improvement of symptoms and is better, you have your diagnosis. You don't need to do a bunch of expensive testing. All right, so next, cow's milk protein allergy and cow's milk protein intolerance. These two things are different, okay? So cow's milk protein allergy is actually IgE mediated. There is an immune response. It's a true allergy or hypersensitivity. Whereas cow's milk protein intolerance may kind of have some of the same symptoms, but it's not necessarily going to be IgE mediated, okay? It's not involving your immune system. All right. The symptoms that you're going to see for children who have cow's milk protein allergy, they will likely have bloody stools. Okay. They will be agitated, sometimes irritable. They're still going to be hungry, but this is another kid you might see mucousy stools in. Okay. Because what did I tell you about what mucousy stools mean? Malabsorption, right? So malabsorption leads to mucus in the stool. And when a child has cow's milk protein allergy, a lot of times we'll see this present in infancy, okay? Usually not later than infancy, to be perfectly honest. It's not as common for you to see a kid coming in at 2 years old with cow's milk protein allergy. It's a lot more common for you to see a child coming in infancy with cow's milk protein allergy once they've started being exposed to cow's milk protein. All right. So you want to look if they're breastfed, because if a child with cow's milk protein allergy comes in with bloody stool, mucousy stool, kind of bloated, the first thing you're going to tell mom if she's breastfeeding is you want to eliminate all cow's milk. And that can be really hard for a mom. And if she tries it and she can't do it, that's okay. All right. It does take 2 weeks, usually 2 to 3 weeks, for cow's milk to completely eliminate from the breast milk if the mother is completely eliminating cow's milk products. But if the child is still having bloody stools when the mom is breastfeeding and you're pretty sure that the diagnosis is cow's milk protein allergy, it is likely that the mom is not eradicating all of the cow's milk from the diet. I want you to think about all of the things that have cow's milk in it. It's a lot. It's horrible, to be honest. I don't think that I could do it. All right. Butter has cow's milk protein in it. Milk, yogurt, cheese, any kind of prepared cakes, cookies, anything that has milk to make it, anything that has butter to make it, anything that has cheese to make it, okay? You are eliminating a lot from your diet to be on a cow's milk free diet. So just remember that when you're educating moms who are breastfeeding that would like to come off of that cow's milk for their infants. If the moms do not or cannot do it, then you can use the hydrolyzed formula, such as the Alimentum or the Nutramigen, okay, or amino acid based formula, such as Pure Amino. But severe allergy, okay, so like we're talking, anaphylaxis. I've only seen that happen once in my lifetime. It was actually very sad. But anaphylaxis or, angioedema, severe highs from head to toe, those kids might not just need partially hydrolyzed formula, extensive hydrolyzed formula, they would need pure amino or amino acid formula, which is a lot more expensive. All right, so let's move on here. Talking about a different thing. Already got that. Okay. So the next thing I wanted to talk a little bit about was intussusception. All right. So children with intussusception, essentially what's going on in their gut is that the bowel is telescoping or invaginating in on itself. Okay. So you can see in this picture here, almost looks like a portion of the gut is like a giant worm and eating another portion of the gut. It's quite weird, to be perfectly honest. Intussusception is a lot more common in infants. Usually we see it in about age between 5 and 12 months old, sometimes a little bit younger. It's really uncommon in children older than 3 or 4. Okay. I would even go as far to say it's uncommon in children older than 2. okay? But the classic triad of intussusception is kind of like a colicky, crampy abdominal pain, vomiting, and bloody mucus stools, okay? The bloody mucousy stools is only present in about 15% of cases, sometimes fewer than that, but if you definitely see bloody mucousy stool in the presence of these two other triadic symptoms, then you really do have a sensitive triad there for your diagnosis. Okay, but what we have found with more and more research and randomized controlled trials is that a lot of kids don't come in with that red curant jelly type of appearing bloody stool that we have for so many years been taught. Okay, and that red curant jelly looking stool looks exactly how it sounds. It's really like a dark red gelatinous stool. You really will not be able to miss it. You'll look at it and you go, yeah, that is not normal. Okay, look like I have strawberry jelly here in a diaper, and that is not something that I want to see. And that bloody gelatinous appearance again is secondary to kind of a malabsorption issue going on in the gut. Okay, so vomiting is non-bilious initially. Some children do not have any pain, okay? But what you'll see is kind of intermittent episodes of screaming and drawing up the legs, and then periods of calm. Because what happens as this peristaltic movements kind of move in on themselves, it causes little bursts of pain, and then the pain stops. And then it comes back, and then it stops. And it's very painful for the child, but then you're going to see them in these periods of calm and sleeping and lethargy between the episodes, okay? So they are like lethargic between those episodes of screaming and drawing up the legs, all right? Okay. So the baby's appearance and behavior over a period of time, you may not see a whole lot except those triadic symptoms on exam, okay? The abdomen is often distended or tender to palpation. Okay, grossly bloody or guaiac positive stools only, again, present in about 15% of cases. This is not something you're going to deal with in primary care, guys, okay? They need to have a barium enema, okay? You may diagnose it on a radiograph if you weren't able to find it when you were examining the patient in primary care, but they need to be seen at a tertiary level center because that needs to be taken care of by somebody other than you, all right? Okay. I know you guys are just loving hearing about all of these GI issues. So I wanted to show you guys this picture of some of the things that you might be thinking about when you're thinking about the abdomen. Having this in your mind will really kind of give you a good idea of diagnoses that may occur. Okay, this is not a definite. It's kind of, this is what you should be considering in your differential list if you have these things going on, okay? So if you have central periumbilical pain, you may be thinking umbilical hernia, small bowel issue, inflammatory bowel disease, stomach issue, pancreatitis, or early appendicitis, okay? And then what did we say about appendicitis? Early appendicitis starts umbilical and then it migrates to right lower quadrant, right? So down here, you may be thinking appendicitis, possibly a pelvic issue. Growing pain is associated with inguinal hernias. Constipation is possible, but I will tell you that constipation is kind of more associated with the left middle abdomen or left lower quadrant pain than the right, okay? So if you've got right lower quadrant pain, I would probably be thinking more along the lines of appendicitis or a pelvic issue or an inguinal issue, okay? And then, you can take a look at the rest of these, but these are just good things for you to know that may be going on with your patient based on pain location on your patient's abdomen. Right. Let's look at acute diarrheal illnesses. Lots of fun. All right. I'm not going to dwell on these, but I want you to have a good idea of common bacterial and viral pathogens because as we talked about earlier in the lecture, viruses are very common for kids and gastroenteritis is very common in kids. And the overwhelming amount of children actually have a viral gastroenteritis instead of a bacterial gastroenteritis, okay? So the things that you want to know is just have kind of a good idea of what are some of these bacteria and these parasites and these viral pathogens, okay? So Campylobacter and C. diff are two bacteria that we do see. C. diff is not quite as common to see like community acquired in kids. It's more often seen, honestly, secondary to antibiotics given, or they were exposed maybe to somebody who has C. diff close in their family. You're going to see explosive diarrhea, sometimes bloody stools, abdominal pain, fever, and nausea with C. diff. But if it's definitely something that should be in your mind if you have a kid who's been on antibiotics recently, especially a child who's been on more than one antibiotic for ear infections. Okay, so let's go over one of the more dangerous ones that I want to make sure you understand. E. coli infections, okay? If you have a child who is older and presents with, and I mean older than infancy, it can definitely occur in infancy, but sometimes we see this in older kiddos, okay, it's preschool to school age. Duration of the illness is about 5 to 10 days, okay? Diarrhea that's often bloody, vomiting, and abdominal pain, okay? They're not necessarily going to have fever associated with it. So, I'm sorry, this does say kids less than 4 years, so up to about the age of 4. But it's dangerous because it can lead to Shiga toxin producing E. coli, okay? And you want to make sure that if you have a kid who comes in to see you with vomiting, abdominal pain, and bloody stools, that bacterial gastroenteritis is on your differential. No blood in the stool with diarrhea and vomiting and, is usually more associated with a viral gastroenteritis type of presentation. Norovirus and adenovirus are also two viruses that can cause an acute gastroenteritis in children, in which case you would be managing their dehydration symptoms. You may be giving them Zofran to help them with their vomiting. You may be considering giving some lactobacillus for their diarrhea, okay? But again, virus and bacterial symptoms are important for you to know the differences between. The second thing, this is the second page, kind of added on, rotavirus. Now, rotavirus is a lot less common now that we've got a vaccine to fight against rotavirus, but it is still one of the more common viruses that present in children under the age of 5, and worldwide it actually contributes to a lot of hypovolemic shock and death in some countries that are still developing. Okay, so acute onset fever, vomiting, and watery diarrhea. Usually the vomiting happens first and the diarrhea lasts for several days after. You really worry about dehydration in these kids. That's the number one issue that you would worry about. Any child who has gastroenteritis is going to be possible ileus and dehydration. And when you worry about severe dehydration, you're going to be thinking about hypovolemic shock in young children. Kids have issues with getting dehydration faster than adults do, okay? That's because their body loses water quickly, and they have more. So make sure you read and understand what these viruses are and what these bacteria are. Bacterial gastroenteritis is a lot more common to have bloody stools. You should not be seeing bloody stools in a viral gastroenteritis, but you may see it in a parasitic or a bacterial gastroenteritis. All right, so I want to talk a little bit about intestinal parasites too. Yum! Here's my favorite one. No, I'm just kidding. I don't really have a favorite. All right, so these are a little bit less common. Okay, honestly, I will talk about the more common ones. Giardia is something that I have seen and diagnosed in practice. Sometimes we see that kind of run through the community at water parks, okay, along with Shigella or some of those other more infectious things between kids that will travel through water. A lot of times you'll also see them kids who have traveled from other countries, okay, or they've traveled to other areas, or they've gone to camp or something like that, and they will have gotten Giardia there. So they may have watery diarrhea, abdominal pain. It's going to be really foul smelling stool, okay? Also bloody diarrhea, lots of cramping, lots of flatulence and distension. These kids really don't want to eat. They may have weight loss. And honestly, by the time they come to see you, it may be a couple weeks already, because it starts off just with some mild diarrhea and then tends to get worse. And so this is what Giardia looks like on microscope. Really brought in and increased as far as the size goes here. But they are parasites, and so they do need to be treated with a specific type of treatment, such as metronidazole usually is the best treatment for that. Correcting, rehydrating the child, of course. Sometimes these kids can be managed outpatient as long as they don't have complicated cases, but a lot of times they have to be hospitalized if it's gone several weeks and they are very young because of dehydration issues and hypovolemia. And the other intestinal parasites that's pretty common is pinworms. Okay, so pinworms, enterovirus is really the technical name for that. But pinworms is something we do see in children also pretty commonly, more than those other parasites. And kids can have pinworms for a while before they actually come in to see you. All right, they can get it from other kids, ingested eggs from soil. It is kind of gross to think about, but they essentially would have to eat the eggs from soil or from contaminated areas, okay? Direct fecal oral route is how they will get it, okay? Possibly on bedding, sometimes clothing, toys, etc., person to person. Female will lay their eggs in the perianal area and then they die, and the ingested eggs will hatch and become larvae in small intestine and migrate to the rectum. This is why you see itching at night, because they will migrate to the rectum at night, and kids will itch all throughout the night, because really at nighttime is the only time you might actually even see any of the worms on the child or out of the child's anus. So if you come in, or if the child comes in and sees you with complaints like perirectal, perianal type of itching, vaginal pruritus, and especially pain at night, then you may not see those pinworms actually on exam, and you wouldn't necessarily wait to see one to even diagnose and treat. You can actually just clinically treat these kids with treatment for the pinworms, even without seeing a worm, if they have all of these symptoms and you're pretty sure that they have gotten pinworms, okay? Mebendazole. So mebendazole is Vermox, okay? So Vermox used to be a really great treatment. It was a one-time pill. The kid took it, but it came off the market. And it has been reprocessed now as something called N-Verm, which is super expensive and really, in most cases, not affordable for a lot of parents. I mean, we're talking over several $100s for a treatment of pinworms. Your best bet, if you don't think you're going to be able to get the treatment for the N-Verm, or there's also albendazole that you can treat with, but the best treatment really is just pyrantyl pamoate, and that's over the counter, and it's called Pinex. Now, we'll say there's only about a 80% treatment success with that. Sometimes they need 2 treatments, so you can tell the caregivers to give one over-the-counter treatment with the pyrantyl pamoate Pinex over the counter, and then in 2 weeks give it again, and then see you if in 4 weeks if the symptoms have not improved. Okay, now kiddos who are less than 2 years old, or if they've got severe manifestations, abdominal pain, bloating, and issues with what you think might be pinworms, really do need referral to a gastroenterologist or a specialist, just to make sure that they don't have anything else going on as a complication. But 9 times out of 10, these kids can be treated outpatient just fine. Okay. So the last thing we're going to go over, guys, is IBD. Okay. So inflammatory bowel disease in children and also in adults is made up of Crohn's disease and ulcerative colitis. Okay, it's important for you to kind of understand the differences between the two, because the symptomology is different between Crohn's disease and ulcerative colitis, as is the treatment, as is the effects of the disease for the lifetime. Okay, typically for inflammatory bowel disease, we see this onset between 10 and 20 years old. So there really is a chance that you will see this as the first person in primary care. And a lot of times what these kids will come in with is weight loss, abdominal pain, bloody stools, maybe not the bloody stool, may just be weight loss and abdominal pain, generally just not feeling well, okay? So the differences between Crohn's and ulcerative colitis, this can affect any part of the GI system, and that really begins with the esophagus and mouth, okay? Maybe the small bowel only, small bowel and cecum, small bowel and colon. Ulcerative colitis only affects the colon and the rectum, okay? So, and unfortunately, the entire colon may be inflamed, infected, that we call that pancolitis, and some children have to have a total or complete removal of their entire colon, and that really can be hard depending on how bad their ulcerative colitis is. All right, so as far as what you're going to see, they both will have abdominal pain, okay? They're both possibly going to have diarrhea, okay? Usually bloody diarrhea is seen more with ulcerative colitis than it is with Crohn's. It's possible to still see it with Crohn's, but it's more common in ulcerative colitis. You can also see weight loss with both of these, but Crohn's diseases more commonly have weight loss than the ulcerative colitis, simply because of the nature of where the Crohn's is affected and how absorption happens, okay? So if you think about how the colon is the only thing affected in ulcerative colitis, absorption happens in the small intestine, all right? So, most of it does. So if absorption happens in the small intestine and we have the Crohn's happening, occurring throughout the small intestine, then we do have a risk of weight loss because absorption may be affected. Okay, and when you're affecting absorption of calories and you're affecting absorption of sugar and other nutrients, then your weight is obviously affected. Okay, so urgency to have a stool is usually more associated with ulcerative colitis, okay? Other things you might see with Crohn's is an ophthalmological condition, okay? So like uveitis or iritis or conjunctivitis, a lot more common in Crohn's disease. Primary sclerosing is possible in ulcerative colitis, but really your eye manifestations are reserved for Crohn's disease. Okay, so how are you going to manage these kids? If you have a child who comes in with what you think might be Crohn's or ulcerative colitis, I want you to be very careful about what you are considering ordering for these children. The laboratory studies that search for Crohn's and ulcerative colitis are very expensive, okay? It should not be your first line idea to order a $1,000 to $2,000 set of lab work, a slew of tests to search for whether or not the child has the presence of the PANCA or the ANCA possible positive lab for these inflammatory bowel disease. I would rather you order simple tests such as an ESR, okay, a CRP, alrighty, maybe a UA also to take a look at what's going on. If you have an ESR and a CRP that are elevated and you have chronic abdominal pain, okay, so these abdominal pain is really going to probably be more chronic in nature, possibly bloody stool and some weight loss, okay, you're going to probably, if you have a positive ESR and or CRP, that is definitely going to be a need for you to refer to a GI specialist anyway. And they would be the ones who would do the actual definite diagnosis of the ulcerative colitis or Crohn's disease because of their specialty. And a lot of times these kids will need an EGD or a colonoscopy as initial treatment, and you won't be doing that. So please reserve those more expensive and, invasive procedures and really expensive lab work for your gastroenterologist, because it may be that this child has something else going on that's kind of like an inflammatory bowel disease present, and you order $1,000 to $2,000 in lab tests because that's how expensive they are, guys. When you're ordering these specific typology and serology testing for inflammatory bowel disease, they get very costly. And if you're ordering those just for them to be negative and the child ends up with lactose intolerance, woo! That's a real big burden on the system, a real big burden on the child and caregiver, and a real big burden on cost. So please think wisely when it comes to inflammatory bowel disease, differential diagnosis and blood testing, and Really your basic ESR and CRP. And then if you're thinking you want to rule out some other things, you may consider ordering an H. pylori test, definitely considering a UA. Maybe a stool test to assess for blood, a stool test to assess for other infections. Those are the types of things you would want to be looking for in a child that has possible IBD, not your really expensive test. That should be reserved for a specialist. If you truly believe that a child has IBD because they have these manifestations with weight loss and bloody stool and chronic abdominal pain and these other symptoms and manifestations, then your first step should be doing lab work that is, minimally invasive and not costly, and referring to a GI specialist. Your GI specialist will thank you for doing those, ESR, CRP, stool tests, H. pylori, and then if they feel like those more expensive tests are necessary, they will order it. But please reserve those things for your specialist, because again, they work in it more than we do in primary care, and they're going to know if it's necessary. All right, as if that wasn't all you needed to hear about gastrointestinal disorders, and there is actually more, but that's the major things that you're going to see in pediatrics. This is all I have for you on your gastroenterology lecture, and until next time.